Thanks, Tuani. I really appreciate it, and thanks, Deirdre and team, for letting me do this. It's a pet subject of mine, and I'm really excited to have the chance to talk about it some more. Poor Tuani and any of my fellows will be getting PTSD for the number of times they've heard me talk about this and seen the slides. But I do think there's real value in us having a fairly deep knowledge and understanding of the physiology of CPAP versus high flow therapy. And with that, when we get to the very last part of the talk, the which to use and when, it's actually really extremely simple. So the mechanism stuff, the anatomy and physiology, there's going to be a little bit of complexity there, but the bottom line at the end, I promise, is going to be really, really very straightforward about the right way to use these therapies and the right way to optimize them. So we're going to talk a little bit about the mechanisms of action. That will be primarily talking about the washout of dead space versus pressure generation. Then about halfway through, we have Kelsey Shaler with us. Kelsey has this wonderful baby live tool produced by Fisher and Paykel, who make the OptiFlow high flow system and many of our bubble CPAP systems. And the first time I saw it a year or so ago, I was really blown away by how tangible it made these questions about the difference between CPAP and high flow. So I really wanted that to come to this online with the experts community, because I think it really lands the messages that I'm going to try and land in death by PowerPoint style, but Kelsey is really going to top off the talk with that demonstration. We'll talk a little bit about the randomized controlled trial data, especially the Hipster and Hunter trials comparing high flow to CPAP, and then we'll do a very brief and very simple summary on which to use and when, bearing in mind the issues with the dead space and the pressure generation. So probably no new information here in these first couple of slides about the mechanisms of action. I think we all know that there is this combination of warmth and humidification. You and I, hopefully all of us, are breathing room air, and our nasal passages are warming that gas and humidifying that gas so that it is gently received once it gets down to our lungs. The dead space washout and end expiratory pressure, where it comes a little bit more complex. But the warmth and humidification, I just want to make sure that we don't scoot straight past that, because it really is absolutely vital. You see here on the bottom right, again, a graph from the Fisher and Paykel online materials showing the optimum range of humidification of gas, and that as soon as we go below that, we end up with thicker mucus that is harder to clear. We start interfering with ciliary action, and eventually we start causing primary cell damage in the respiratory epithelium. I think any of us that were putting on babies on any more than even half a liter of flow, I hope most of us would automatically be warming and humidifying that gas. And I'm going to take that as read for the rest of this talk, that any high flow or CPAP we use is always going to be fully warmed and fully humidified. Happy to discuss that more at the end if necessary. But the dead space washout, I think, is where many of us, I think, have an underappreciation of quite what's happening. So let's dive into that a little bit more. When we think about the dead space components, we could think about that in a few different ways. I choose to think about the anatomic components of the dead space as the supraglottic component, which is pretty much marked in red on the image on the left here, and then an infraglottic component that's in this image in the right. There is, of course, you'll remember, a physiologic dead space, i.e. even for gas that gets down into the terminal bronchioles, it doesn't necessarily exchange effectively, but I'm not going to talk about that physiologic dead space. I'm only going to talk about the anatomic dead space. We all, of course, remember, and it's very obvious to us, that our babies' heads are disproportionately large relative to the rest of their bodies compared to any other subject population. And that means that their dead space is also disproportionately large This is a paper that some of my residents did when I was in New York, and we dug out some CT scans of babies with normal anatomies and 3D carved out their volume of dead space. And the volume of the supraglottic dead space was around 1 mil per kilo in infancy, but was up to around 2 mils per kilo in babies at 2.5 kilos. And we didn't have any CT scans much smaller than that. Kelsey's going to show you the Fisher and Paykel CT scan in about 20, 30 minutes time. So we think the supraglottic space in NICU babies, it's probably easiest to summarize it as being around 2 mils per kilo. And it's not just us that said that, actually. The Airway Jedi group, which is a wonderful website for some of this discussion, and a few other papers, all suggest that the supraglottic dead space is around 2 mils per kilo of weight. The infraglottic dead space is probably another 1 mil per kilo. So we're at 3 mils per kilo of anatomic dead space before we consider any physiologic dead space. So what does that mean? Well, it means that for each tidal volume that we all know that we dial in 5 mils per kilo in the first instance in our ventilators, and that dead space, that tidal volume seems to be about the same in babies that are breathing CPAP or high flow or not on any respiratory support. Well, that means that of each breath, which is 5 mils per kilo, 3 mils per kilo is dead space. That's 60% of each breath is waste gas. Every baby that we look after is trying to breathe out that gas before it can breathe in fresh gas from the room or from the respiratory support. So if that fresh air that we are all breathing at the minute is 21% oxygen and essentially zero CO2, expired gas in general is about 5% CO2, and therefore there's only about 16% left for oxygen. So, apologies if this math takes a couple of goes to get through. I'm not going to spend too long on it because many of you will have this math in your head already, but I just want to point out that as a baby is sitting not on any respiratory support, 3 parts of its breath are 16% oxygen, 2 parts of each breath are 21% oxygen. So the effective inspired oxygen that gets down to the baby's lungs is 18% rather than 21%, because 60% of each breath is 16% oxygen rather than 21% oxygen. So although we think of all babies are breathing 21% oxygen, in fact, our babies are probably breathing 18% oxygen. What does our respiratory support do to that? This paper is going to come up a couple of times. I've put the references in each of these, and if anybody wants any of the references, feel free to email me. I have these all, of course, happy to share. This Lou paper, for me, is the best observational demonstration of high flow versus CPAP in the NICU. Came out 4 or so years ago. This team took 48 babies with a median gestation of 32 weeks, but they went down to 28 weeks. A median weight at the time of the study of 1250 grams, but they went down to 610 grams. And they measured nasopharyngeal and expiratory CO2 levels. They randomized the order in which they gave these babies different types of respiratory support, and the randomization sequences are on the right-hand side. So in group 1, they started those babies on CPAP of 6, and then they transitioned them 30 minutes later to high flow of 8 before winning down to high flow of 2. And in group 2, they started on high flow of 8 down to high flow of 2, and then at the end, they put them on CPAP of 6. So CPAP was either at the very first 30 minutes or the last 10 minutes of the study, and hopefully, therefore, we've got a reasonable crossover that there's no systematic reason why high flow should appear differently from CPAP in this cohort. This table is going to come up a couple of times, but for now, I just actually want you to focus on this bottom line here, which is the percentage CO2 at end expiration. So on a high flow of 2 liters, the CO2 is about 2.3%, and it gets washed out all the way down to 0.9% the more high flow rate you put on. In contrast, CPAP doesn't seem to give even as much washout as the level that we're getting on a high flow of 2. So the more high flow you give, the more washout of your dead space that you give. And CPAP, not much washout at all. One of the things that's going to come up again, time and again in this talk is whether we should be thinking about our high flow dosing in liters per minute, or whether we should be thinking of it in liters per kilo per minute. And unfortunately, there's no one-word answer to that question. So I'm going to talk about both each time so that we can look at the pattern each time. So here is the high flow rate just in liters per minute. And then when we think about liters per kilo per minute, let's just look here that on 2 liters, the smallest babies, i.e. higher liter per kilo per minute, obviously have more washout than the larger babies at the same flow rate, less washout. So the higher the flow rate, the more CO2 washout. The smaller the baby, i.e. the higher the flow rate in liters per kilo per minute, the more the CO2 washout. Seems pretty straightforward. I don't think it's controversial, but again, I do want to highlight CPAP is not driving much CO2 washout. And I do want to talk just briefly about the efficacy of this CO2 washout. If you can wash out the entire supraglottic space, that's 40% of your tidal volume that was dead space is now becoming nice, fresh, warm gas with 20% oxygen in it. That has to be a significant reduction in work of breathing in terms of the infant not having to warm that gas, not having to humidify that gas, and not having to rebreathe all that waste CO2 that it really doesn't need. So even relatively low high flow rates, 2 liters per minute, are doing a pretty good job of decreasing the baby's work of breathing in terms of the warmth, the humidification, and in terms of the CO2 washout. So let's talk about end expiratory pressure. And end expiratory pressure is really the only thing I want to talk about, because end expiratory pressure for us in the NICU, of course, is everything. We know that we use CPAP all the time, and we know that CPAP has produced this extraordinary paradigm shift of how we give respiratory support to our babies in the last 20 or 30 years. Many of you will have seen these videos before, and I'm sorry, I meant to give a little alert for anybody eating their lunch before I pull this slide up, but you've all been to medical school, so you all expect a little bit of gore. This is a rabbit lung, and this group took out this rabbit lung from the animal. They put a small endotracheal tube into it, and they're going to demonstrate to us the difference between whenever you provide PIP without PEEP between breaths and whenever you provide the same PIP but with PEEP between breaths. So these first 2 breaths that we're going to see on the screen here are a PIP, I believe it's of 20 centimeters of water, and then with no PEEP in between breaths. So this is PIP and no PEEP. PIP and no PEEP. And obviously we're seeing total collapse down of the lung. Now in this next video, hang on, sorry, one more. In this next video, we're seeing PIP and now with a PEEP in between. PIP with a PEEP, PIP with a PEEP. And now, of course, we're starting to see some beautiful lung development with those lungs coming almost fully open. Let's look at that again. PIP with PEEP, PIP with PEEP, PIP with PEEP. So the other thing I want to try and point out in these images is clearly this lung expansion looks vastly better. But I do also want to point out, even with this glorious lung inflation all the way through, there are still these stubborn parts that haven't fully opened up. And it takes a long time and PIP and PEEP and time to get to full lung recruitment. And now finally on that breath, we've gotten to full lung recruitment. And I really encourage people to think about what we're doing on our babies as lung recruitment measures, Because when we talk about increasing the CPAP, that's probably what we're talking about. When we talk about increasing the PEEP on the ventilator, that's probably what we're talking about. We're talking about driving the overall lung recruitment. We're maximizing our functional residual capacity. And what we saw on the image a few seconds ago, whenever a few stubborn bits of lung were not fully open, is obviously much more marked in our babies with evolving BPD or severe RDS, where many areas of lung are atelectatic, and we really want to be making the best use of our lung recruitment maneuvers to maximize that lung inflation. Here's another example of this same work. This is now a rabbit lung where they're measuring the lung gas volume. This is from Argentina in their group in Australia. And again, what they're doing each time is that they're applying the same PIP to the lung. This is from initiation of respiration through the first 30 seconds or so. And on the bottom graph, we have a PIP, but with no PEEP. And on the top graph, we have a PIP, but with a PEEP. And very compelling, of course, that with the addition of a PEEP, we are getting much better establishing of our FRC. And again, you all remember from your medical school hysteresis curves that by getting some FRC, this is the easiest position for babies to be breathing in. Having their lungs fully open like this dramatically decreases the work of breathing because they've already got some established FRC. So we all acknowledge, I think, that PEEP is key. We all acknowledge that we are talking about lung recruitment maneuvers whenever we're giving these things to our babies. And this is just the US data on first recorded respiratory modality in preterm babies. This pattern shows us, even just since 2008 to 2018, how dramatically we have all invested in our NICUs in giving our first respiratory support a CPAP rather than in intubating and ventilating. So our primary support mechanism now, 65, 2/3 of the time, is CPAP or NPV, with a small number of units using some high flow, and some babies, of course, still needing to be intubated. But you know, when you walk around your unit, that the majority of babies that you see, small babies, are on CPAP. So that then brings the question to what are the pressures that we're generating on high flow? And this is the point at which the short answer is it is almost impossible to predict in any individual baby what pressure is being delivered if that baby is on high flow. There are multiple studies that have looked at this. I've only chosen the 4 or 5 best studies. I've got multiple slides at the end if people want an even deeper dive than that. Some of the variability in results can be explained by slight difference in methodology. So for example, some studies look at the mean airway pressure as opposed to looking at the end expiratory pressure. For us that used to looking at CPAP, we are used to considering end expiratory pressure as our PEEP, as our pressure measure. But mean airway pressures probably aren't that much different. They're probably only 0.5 or 1 centimeter of water different. A number of studies use esophageal pressure rather than pharyngeal pressure. Esophageal pressure tends to be a little bit lower because not all the pressure gets transmitted. But the bigger differences, I think, that we're seeing are the infant size, depending on the flow rate that we use, in particular, the size of the prong compared to the size of the baby's nose, and also whether the baby's mouth is open or closed at the time of the study seems to have a significant impact on pressure generation. So let's go back to this loose study again, where again, they had 48 babies, 32 weeks-ish, 1.2 kilos-ish, and some of the babies started on CPAP and then went on decreasing high flow. Some of the babies started on high flow and then were switched to CPAP. And here again is the table where I showed you the end expiratory CO2 previously. Now this is end expiratory pharyngeal pressure. So I think this is our gold standard for pressure. And if babies were on 2 liters per minute, they were generally only getting a PEEP of about 2. And if they were on 8 liters per minute, they were getting a much higher PEEP of about 6. And you should be relieved to see that if a baby was on a CPAP of 6, they were getting a PEEP of 6, as it should be. So higher flow, clearly increasing your PEEP. And then another set of rows here with the mouth closed versus the mouth open. In each case, higher pressure with the mouth closed than with the mouth open. Not dazzling information, but again, I want to focus that the size of the baby, i.e. the flow rate in liters per kilo per minute, also has a factor. So for babies on 2 liters, a baby under 1 kilo is getting a lot more PEEP than a baby over 1.5 kilos, and the same at each of these different flow rates, 2, 5, and 8. I could have shown you every liter per minute rate. They all follow the same pattern, but I didn't think that would be terribly helpful for you. But one of the other things to look at this is that although we're saying that with higher flow comes higher PEEP, have a look at the variability in this. Have a look here, for example, on flow rate of 3 liters per minute. Yes, the population average PEEP was 3, but the standard deviation was 1.6. So that means that some babies, 5% of babies, will have had 2 standard deviations less than this, so a PEEP of 0. And 5% of babies will have 2 standard deviations above this, a PEEP of 6, on a rate of 3 liters per minute. And again, same spread across all these numbers. And while you might hope that by showing those numbers in liters per kilo per minute, we would get less variability, actually, that's not what we see. So here's end expiratory pressure on the y-axis and flow as liters per kilo per minute on the x-axis. Now, in the older child, many of you will have looked after kids with bronchiolitis in the PICU and started them all on 2 liters per kilo per minute of high flow for the 6-month-old with bronchiolitis. Well, in our babies, if we choose that 2 liters per kilo starting dose, some of our babies will be getting a PEEP of less than 1, and some of our babies will be getting a PEEP of more than 6, and with every other number in between. So again, the key point here is the huge variability in PEEP that we're generating whenever we're on high flow. I promise I haven't cherry-picked this study to try and make my point, so I'm going to show you a few more studies that had similar methodology. Here's Wilkinson et al., one of the first studies that looked at this 15 years ago. Similar size of babies, 33 weeks, 1.6 kilo babies. Now here they've looked at mean pharyngeal pressure, not end expiratory pharyngeal pressure. So we can probably add a 0.5 or a 1 to that. But again, here are babies with flow in 2 liters per minute. And some babies have no PEEP at all. And again, some babies' PEEPs are up to as much as 6 and every number in between. So huge variability there. The IRIS study, again, similar concept, similar size of babies. These babies, again, now looking at esophageal and expiratory pressure, so we can probably add a little bit of extra pressure to this because your pharyngeal pressure is probably a little bit higher than that. These babies on average at 1.5 kilos, seeing, again, at 2 liters per kilo, so that's 3 liters per minute, PEEPs of 2 to PEEPs of 5. And up here, once we're giving higher pressures at 8 liters per minute, PEEPs as low as 5, quote, low as 5, or as high as 15. So sometimes, whenever we have our babies on high flow, we are deliberately, or I'm going to make the case that in most cases, I don't think we know we're giving a PEEP of 15. I think we are often inadvertently giving this kind of high PEEP whenever we look at our high flow in liters per minute, or whenever we did it here previously in liters per kilo per minute. And from the Lou study, all of these graphs have babies going up to PEEPs of 12, 13, 14, way higher than any of us would feel comfortable dialing into CPAP. And one of the things that I think seems like a really obvious solution to this is just to measure the pressure. So we do have a couple of people on the call from this group, DRW Medical. This is their Napa LP15 device. I think a lot of NICUs in the US already have this device in the NICU, primarily to monitor the pressure being generated while on bubble CPAP, so that you get an alarm whenever the CPAP is no longer achieving a good seal. But there's also an adapter that comes with this monitor that you can use to put 1 to 2 centimeters into the nares alongside the high flow to measure the airway pressure while on high flow. My group here have just started recruiting to a prospective study where we are doing that on a range of babies on room air, high flow, CPAP, and ventilated. And I'm quite sure we'll see the same kind of numbers as all the other studies that we've looked at. But one of the things I'm hoping to be able to prove to my team is that we should include this in our standard clinical protocol, that anytime we put a baby on high flow, we should measure the pressure that we're generating rather than having to guesstimate how much we're giving. I think DRW Medical have a newer version coming out. My one concern with this version is that it does measure mean airway pressure, and it's not telling us what the difference is between inspiration and expiration. And Kelsey, in just a minute, I think is going to give you a really compelling demonstration that we really need to think about that whenever our babies are on high flow prong setups. I do, however, want to make sure that we are being fair in judging our high flow variability versus our CPAP variability, because I had always assumed, foolishly, that CPAP guarantees a constant pressure. But that's actually not what we see. So in this Lou study, where we see this degree of variability in pressure with high flow, there's also quite a lot of variability on pressure generated while on CPAP, which I'm going to assume is from a combination of factors of the sometimes being a leak around the mask with the prongs that's going to drop your pressure. Sometimes with the mouth being open is going to drop your pressure. And sometimes if your flow rate is high and your CPAP is bubbling aggressively, then that's going to increase your pressure, as is the presence of any rain out, any water free in the expiratory limb of your circuit. All those things are going to drive up your CPAP pressures. So yes, I like the comfort of thinking a baby on a CPAP of 6 is receiving a CPAP of 6, but they might not be. They might be receiving a bit more than that or a bit less than that. And the Alalayan and a few other studies, again, have all shown there's a bit more variability with the pressure on CPAP than we would perhaps like to believe. Here's the impact of condensate in the expiratory limb. I was really embarrassed when I found this paper this year that I didn't know about that. I don't normally check the expiratory limb of my CPAP circuits and kids in bubble CPAP, but the next time you're rounding, have a look at the expiratory limb and lift it up and tip it out into the baby's bubble CPAP container. Please do tip it out in that direction. Don't tip it back into the baby's nose. Please do tip it into the bubble CPAP container. But you may well find that quite a few of your babies have got 5 or 10 or even more mils of water in the expiratory limb. And clearly that has a dramatic increasing effect on the CPAP pressure that we're delivering. The strength of that bubbling also seems to have a great big impact on the swings and pressure through the respiratory cycle. So here's the gentle oscillation that we see in all babies on bubble CPAP. Some people believe that these oscillations help with CO2 extraction in the same way as we do with babies on the oscillator. Some people think that's less of a significant component. I really don't know. But I think we would all agree that whenever we're seeing these very wide swings of pressure, dropping down to 5 and then up to about 12, that swing of pressure is probably not great for our babies to be getting. If my first take-home message was that the pressure generated while on high flow was quite unpredictable, my second take-home message, and I only have 2, is that the size of the prongs relative to the size of the nose really, really matters. We are very used, and our respiratory therapists and our nurses are very used to babies on CPAP prongs having to have the prongs all the way into the nose and generating a seal so that there's no leak. But that is not how high flow is meant to work. High flow is meant to work with around a 50% leak around the nares. RAM cannula, and many centers are still using RAM cannula, is meant to work with around a 20% leak around the prongs. But it's really hard to see that in our small babies. It's probably very variable as the prongs move in and out. But this factor of the leak can have a really dramatic impact on the pressure generated. Here is an adult study where it's a bit easier for them to measure the size of the nose and the size of the prongs and show that if you've got a less than 50% leak here, you can see some slightly higher pressure. But as your leak goes down to 35% here, you get this enormous bump up in pressure generation. So during the COVID pandemic, when we had adults on 60 liters per minute, I'm not surprised that adults do great on that because we're giving them a PEEP of 12 if we've got a generous size of prongs or if their nose is on the small side. It's a little bit harder to find data in that in the NICU population, but the same trends are there. You have to dig deep into this Lou paper to find that data. But here they are just dividing babies into a low leak, a 30% leak, and a less than 30% leak, and a high leak, a more than 30% leak. So both on the low side of what the manufacturers recommend, showing that on a PEEP or a flow rate of 4, for example, your PEEP can change from 3 to 4.5, just based on the amount of leak around your prongs. That prong size really, really matters. The prong size really, really matters for 3 reasons. Number 1, to minimize the inadvertently high PEEP. Number 2, we need to have the prongs with some leak around them in case we're not putting enough flow through the prongs to meet the baby's maximal inspiratory flow. And we need to make sure that we leave some space around the prongs for the babies to breathe out, because the babies cannot breathe out through the prongs. The pressure is too high in that setup. They have to breathe out around the prongs. And Kelsey's going to go into that in more detail. But I do want to talk about this peak inspiratory flow. It's sometimes called peak tidal inspiratory flow. It's sometimes called maximal inspiratory flow. It should be a really easy concept for it because we've all looked after people with asthma where we measure their peak expiratory flow rate. We're very comfortable with what that number looks like. We don't tend to think about peak inspiratory flow rate, but it's obviously just as important. And that's the highest flow rate that's happening during inspiration. What is that flow rate? Well, in healthy babies who are on the newborn nursery, it's just under 1 liter per kilo per minute. In babies with BPD, it's a little bit higher at 1, but again, a reasonable range here. So 1.5, we can certainly see in babies with BPD. And in babies who've just been born, the peak inspiratory flow rate is much higher than that. The average peak inspiratory flow rate in the delivery room is 2 liters per kilo per minute, but again, with a very wide range. And again, it's something that's relatively hard to be sure what that number is, but it's primarily driven by your tidal volume, of course, and your inspiratory time. But if you carry around that it's almost never less than 1 liter per minute, that means that if you're ever giving less than 1 liter per kilo per minute of high flow, you're probably not matching that baby's peak inspiratory flow demand. So anything less than 1 liter per kilo per minute, I want to ding an alarm bell for you that we almost certainly aren't giving that baby much inspiratory flow. And 2 liters per kilo may well be required to match the peak inspiratory flow rate. But of course, as your respiratory distress worsens, your tidal volume worsens, your respiratory rate increases, and therefore your inspiratory flow decreases, then your peak inspiratory flow rate is going to go up and up. So in the adults, they suggest, and I'm sorry, there's a typo on the screen here, they suggest 10 times your minute volume should be your best estimate of what your peak inspiratory flow is. So that's me doing a lot of talking, a lot of slides, a lot of data. I do have a few more, but I really want Kelsey to show the demonstration with the baby Liv. So I think if you guys are either on speaker view or if you pin Kelsey, you'll be able to get a close-up view of this baby Liv. And Kelsey, thank you so much for joining us for this. I really, really appreciate it. I'm delighted for you to show off what we can learn from the baby Liv.
Absolutely. Thank you for having me. Everyone can hear me, I hope, and someone will say something if they can't. So we're going to walk through a little baby Liv demonstration. Baby Live, Live stands for Lung Inflation Visualizer. So what Baby Live is, and I tend to call her a her, so sorry if I do that during the presentation, but we do have what our engineers did is they took multiple CAT scans of 750-gram babies. They took an average of those airways and they created a 3D printed airway that we have back here. So it is anatomically correct, although rigid. That would probably be its biggest downfall. And then we do have a pressure manometer, try to make it visible here, right here in this upper airway. So we are able to put different therapies with different interfaces onto Baby Live. She also has an anatomically correct face, and we can kind of see what those pressures that are being generated are. I have connected the screen that's here to an iPad screen to hopefully make it a little bit more visible. But if you have any trouble seeing it at any point, just let me know. But we're going to simulate some different pressures here. So to kind of set a baseline whenever I'm doing a demonstration with Baby Live, I always like to start with a true CPAP interface. And that's for a lot of the reasons that Dr. Grove just went over, right? But we are going to be able to set a pressure and get what we're setting when we use an interface like this. A couple of important reasons for that, right? The seal is an obvious one. So as he was mentioning, you're either going to have prongs that fully occlude the nair, or you're going to have a mask that creates a seal. You're also going to have large tubes. So these tubes are about the same size as the circuit. So we're not having any resistance to that pressure we're trying to deliver. And then also really important is that oh shoot, just went to sleep. Of course, I've been keeping it awake this whole time. And on this interface is that we do have exhalation possible right at the baby's at their airway. So when they're exhaling, that gas exchange or that expiratory limb is right here at the baby's nose, rather than when you're using a cannula, like he was mentioning, they really can't breathe out through these prongs because the flow is coming in from both sides. They would have to get past all of that pressure coming in and then get back here to actually have effective gas exchange. But there is no expiratory limb, which makes it, very difficult for them to breathe out if you were to fully occlude with a cannula. So let me just wake this up really fast so that I can actually do a demonstration for you. And of course,
that's great, Kelsey. Thank you so much. And that again, embarrassing for me, is something that I just hadn't stopped to think about until I saw the Baby Live for the first time. Babies breathe out through the CPAP circuit. We know that. That's how we control their end expiratory pressure. But babies do not breathe out through the high flow circuit. They have to breathe out around the high flow circuit.
Correct.
How's that iPad doing, Kelsey?
Of course, it's thinking. I had it ready this whole time, keeping it awake, and then I talked too long. I should have a timer on myself.
Probably me talking too long, isn't it?
I'm like, I should just cut myself off if I see it. We're going to give it just a second. While it's doing that, just to kind of explain Baby Live as well, I do have a flow generator over here on the side that will control my flow per minute. It's a little bit loud, so I apologize if that creates background noise. And then I also have the circuit hooked up to a bubble CPAP generator for this first part. And I do have the bubble set at a CPAP of 6. So I will do that just momentarily. I don't know why we're struggling here. Give me just a second. I do apologize. See if we can get it to load.
And if that doesn't work, Kelsey, we can probably just zoom in enough on the screen on the Baby Live. But I think
we got it. All right. Sometimes you just have to quit the app and restart it. So here we are. Sorry about that. Okay. So I am going to crank my flow up to about 6 to 7 now. So again, I apologize for any background noise. It's not the quietest thing. And I'm going to put my little mask on my Baby Live here. Again, we're going to create a line. Oh, is it working? Yes, there we go. So we're going to see that pressure line over here on the iPad. If you can see, it does give you the exact pressure up on the top. Dr. Groves was mentioning, you have those oscillations from the bubbler there, but that mean pressure is going to be about 6, which is what I have it set at. I'm going to try to use both hands here. This is why CPAP is a fun interface to do. I'll simulate some breaths here so we can see that pressure does stay relatively, if I can keep a seal, does stay relatively consistent with little spikes and declines depending on how hard that work of breathing is. But if they're not working too hard, we're not going to get super large variabilities of pressure. So I'm going to
So
go.
with CPAP, we're very consistently hitting between 6 and 7 centimeters of water. And even with Kelsey manipulating that lung to put a bit of forced expiration in there, we're still not seeing the PEEP climb above 7 centimeters of water.
Correct. So now what I'm going to do is I'm going to go ahead and remove my expiratory limb. I'm disconnecting my bubbler. I did save that line, pardon the drastic drop there in the middle, but that's what happens when you have a leak. Great demonstration there. So now what I'm doing is I'm just hooking up a OptiFlow high flow cannula just to the inspiratory limb. No, you're not allowed to go to sleep. So that we can see what high flow, and this is our smallest cannula. So this is actually the size that would correctly fit this 750 gram baby. Again, about 50% occlusion. We kind of got away from saying that just because people get a little bit too focused on that 50%, but we do want a visible gap. So I say about half the nair is what you want to fill. And that prong size really does matter. And again, with these babies, if you fill too much of that nair, what you're really going to do is create probably an increased work of breathing rather than a reduced, which is one of the goals of high flow, right? And we did mention as well how important it is to meet or exceed that peak inspiratory flow demand. That is when you get all of those benefits of high flow, where those mechanisms are really going to do their job. And I'm going to demonstrate that with a few different flows, but I'll go ahead and turn up my flow now. And you should, once I start this. So I am going to turn this up to about 6. The data does recommend in a neonatal population. There are several studies that recommend starting between about 4 and 6 with a max of 8. Ooh, sorry about that. So now should see a red line appear here. And again, this is about 6 liters with this small cannula that fits about halfway. If I don't, push it too far into the nose, we don't want to occlude. So you can see it's a much more level line, right? I haven't simulated any breaths yet. So I'm going to try to do that now. So pardon my little. So when I simulate some breaths though, we can see that variability, and that's really going to depend on how hard that baby's working, right? Sorry. And so really what Dr. Groves is talking about is with high flow, right? The pressure really is unknown because obviously we don't have this screen when we have high flow on a baby in real time, but this gives you an idea of what that baby really might be experiencing in terms of pressure. And I think something that's really important is that drastic swing in the line, right? But you do want to note that we never hit 0 in terms of pressure on that inspiratory side, right? So obviously our pressure drops, but when we're truly meeting or exceeding that peak inspiratory flow demand, which is again, the main goal of high flow so that we can see the benefits of it, reduce that work of breathing, actually provide a little bit of that positive pressure. We want to make sure we never hit 0, right? We never want to fully lose that recruitment we're trying to provide with high flow. Sorry, I can't see the other nair. There we go. And so that's really important when providing enough flow as well. Any questions there? Let's see if I can put a little bit of a twisted cannula here. So I'm going to do this a little bit longer so I can save the line for you. But I do want to show, even when properly fitting, if I were to turn this down, not up. So if I turn this down to, let's say 3, which I know a lot of people, this is where we get comfortable with high flow in the NICU. Maybe we get a little bit nervous about flow because again, we don't know what that pressure is and we're very comfortable with CPAP. You can see how much less pressure we're delivering and how, depending again on how hard that baby is working, we're probably going to hit 0 or go into negative pressure, right, on inspiration. Oh, nope, every time with those breaths, which is what we want to avoid. And so if we're delivering high flow, it's really important to use enough flow to actually get those benefits of the therapy. And so I'll turn that up just a little bit. So again, to remind you what 6 looked like, we stayed up here. And at the beginning, when I had the, cannula way too far in the nose, that's when we run into some issues, right? Because that baby has nowhere to exhale. They're probably going to spit out their pacifier, open their mouth, right? This baby doesn't have a tongue, so I have to keep a pacifier in to kind of give you an idea of what it could look like. We don't recommend a chin strap or anything though with high flow, but just to give you an idea of why it's so important to fit that prong right as well. But I will show you a different size cannula to give you that idea additionally. So I'm going to go up a size now. when I do that. So this is our next size up. This is going to fill probably about 90% of the nair, I would guesstimate. When I look at this guy, let's see if I can, always a little tricky upside down. But we're gonna try again. All right, and this line should be green if you all can see it. I know this one's probably the hardest color. I don't know why they had to choose neon green, but it does make it a little bit tricky to see. But if you can see, we are getting a little bit of those higher pressures, and I'm at 6 liters still, but I'm looking more in the world of what we were getting with CPAP, right? But that just means that with that variability could mean those higher spikes of pressure. And again, it's going to be a lot harder for this baby to get rid of its CO2, to really exhale properly. And really that washout that we talk about so much with high flow is going to be a lot more difficult because they have to breathe around more of that prong. Depending on how high we up in that nose we put the prong, again, we could see some really increased pressure. So that prong fit is really, really important, as well as using enough flow to truly get the effect of the therapy and support the baby. The other side of that is, and I'm going to turn this down for just a second because I feel like it's really loud. Maybe it's just on my side. But the other side of that is if we occlude the nairs too much and we don't provide enough flow, one, we're not providing enough flow to really stay above zero, maintain a little bit of that recruitment, right, for these patients. But at the same time, we're occluding their nairs and making it harder for them to exhale. So when we go down to those 2 or 3 liters, we're really not providing much support for these kiddos. And at the same time, you're making it harder for them to exhale. So also, I always like to caution people, you know, once you get down to those lower flows when you're weaning, one, you want to make sure your cannula is fit really properly. And that's why that about halfway filling the nairs is so important. But when we're getting down to those really low flows, thinking about how much support we're really providing. And if your patient starts to decline, do we need to go up on our flow? I see a lot of the times folks going up on oxygen when they've already weaned down to those lower flows because they don't want to go back up on the flow. That can impact feeding and things like that. But a lot of times that can falsely inflate what they need in terms of oxygen, right? So thinking about the way those two things play a role as well. Dr. Gross, I didn't know if there's anything else you wanted me to add in terms of this demonstration.
No, Kelsey, that's absolutely amazing. Again, I really, really appreciate it. I find it such a graphic demonstration of how this CPAP provides a knowable and relatively stable pressure. The high flow provides an unknowable pressure and a pressure that changes radically through the respiratory cycle. And that pressure changing through the respiratory cycle just means that there's too much resistance on inspiration if we're not meeting the baby's inspiratory demand. And there's too much resistance on expiration. So we're giving an inadvertently high PEEP, both of which are bad. That's making the baby's breathing harder for them whenever they breathe in and harder for them whenever they breathe out, when we're meant to be here making babies' breathing easier for them.
Yeah, awesome. And I did want to know, and this isn't like a plug at all, this is just an education tool, but I do have colleagues across the country. I know there's a lot of you in all different locations, but if you feel like this demonstration is helpful or you would like, you know, other colleagues to see it, please let, you know, someone on the call know and reach out to me because I'm happy to have someone come in person and show this as well. I know it's a little bit tricky virtually, but I have a team of people across the country where we really are just here to educate and show you things like this. So if you feel like it'd be helpful, I'm happy to share that with my colleagues wherever they might be.
Thanks so much, Kelsey. I really appreciate it. I'm going to run through the last slides just in the last 5 minutes to make sure that we finish on time. Many of you will have read the Hipster and Hunter trials or journal club them. And if you haven't, I just want to summarize them each here. They're 2 very similar trials done by the same group in Australia. They're both trials of CPAP versus high flow. In each case, the Hipster trial is primary therapy in preterm babies. The Hunter trial is primary therapy in term or near-term babies. And I'm going to talk a little bit about comfort and parental satisfaction on CPAP versus high flow. Here's Hipster, wonderful, wonderful study, 564 babies. You had to be 28 weeks to enter the study. You had to be preterm to enter the study. They randomized to either CPAP or high flow within 24 hours of birth. And I really want to focus on how much flow rate they started on. They started in these small babies on 6 liters per minute. and increased to up to 8 liters per minute on high flow before saying that the babies had failed that therapy. CPAP, they started at a pressure of 6 and went up to a pressure of 8 with a max CPAP pressure of 8 centimeters of water. They had pretty tightly defined criteria for when the treatment was deemed to have failed. Same for both studies. Either your FiO2 was above 0.4, or you had a pH of 7.2 with a CO2 more than 60, or you had a set number of apnea episodes per hour on the NICU. The trial, published in New England Journal, very well conducted, clearly well-matched high flow and CPAP groups. So we really feel we can believe these findings, and a very compelling difference in the primary outcome measure, the primary outcome measure being a treatment failure. The treatment failure rate was twice as high in the high flow group as it was in the CPAP group. And that seemed to be the same pattern in babies less than 32 weeks or more than 32 weeks. Pleasingly, though, not huge differences in how many babies needed to go on to be intubated with that. Because, of course, with failure of the high flow group, your first step with failure is to just switch on to CPAP. So if you do start with high flow, you can often rescue these babies with CPAP without necessarily going on to intubate. There's a slightly higher rate of intubation, but not statistically significant. The majority of the treatment failures were for FiO2 rather than blood gases, and otherwise in the outcomes, there wasn't a big difference in days of respiratory support, 4 versus 3 days, so a slight difference. There was quite a big difference in nasal septal injury, with the rate being twice as high in the CPAP group. Hunter trial, very similar design, just slightly bigger babies. So you needed to be more than 31 weeks to get into the Hunter trial, slightly bigger study. You had to be over 1,200 grams too. But again, randomizing in the first 24 hours to CPAP or high flow, again, starting on high flow of 6, maximizing to 8, CPAP 6 to 8, maximizing to 8, and the same treatment failure criteria. Again, very much preoccupied with term babies. You could go down to the smaller babies, but in this case, only 20% of babies were less than 34 weeks. So Hunter is really telling us predominantly about term babies. Again, very well matched between the two groups, but again, significant differences in failure rate. So again, the high flow group, twice as high a failure rate as the CPAP group. Same at less than 34 weeks and at more than 34 weeks, but no difference in needing to be intubated in this group, no difference in need for surfactant, or much difference in duration of respiratory support, 5 hours more respiratory support. So again, a much higher failure rate in the high flow group, but then just rescuing those babies with CPAP. So high flow 6 to 8 is clearly inferior to CPAP, but the primary mechanism is just escalating to CPAP, and not much difference in intubation rate, pneumothorax, or length of stay, minimal difference in duration of respiratory support. It's not unreasonable, therefore, to start some of these babies on high flow if we accept that a bunch of them are going to transition across to CPAP. The one thing I would say from my group, our practice policy is to not allow oral feeds unless the babies are on 2 liters or less of high flow. I happen to disagree with that cutoff, but it's the consensus among the practice, so that's what we'll do. But it does mean that we're often trying to get these babies down to 2 liters, and putting a term baby on 2 liters, honestly, I would argue is homeopathy rather than respiratory support. I do want to briefly mention comfort, because one of the questions I'm often asking at the bedside whenever we're considering high flow versus CPAP is, does the baby hate CPAP, or does the baby hate CPAP yet? And certainly there's a bunch of studies suggesting that babies prefer to be on nasal cannula, but of course, knowing that they might not be getting the support that they need on nasal cannula. Here are their PIP behavioral scores. Here are their salivary cortisol levels from this study by Osman. Clearly, babies are more comfortable on high flow than they are on CPAP. And if you ask their parents about them, even though their behavior isn't much different and the noise levels aren't much different, parents clearly think that their babies are more comfortable, that they can interact with their child better, and it's easier to be involved in the baby's care. And very interestingly to me, in these babies that were crossed over from high flow to CPAP, the baby's respiratory rate was actually lower on high flow than in CPAP. And I wonder if that, again, is a comfort issue. So I've hopefully reminded you that high flow and CPAP both provide warmth and humidification, and that's really important. High flow seems to be better for washout. CPAP seems to be better for reliable PEEP generation. High flow seems to be better for comfort. High flow rates and high flow may give us far more PEEP than we ever intended. 15 centimeters of water is a crazy high PEEP. Low flow rates, anything less than 1 liter per kilo, may really just be getting in the way of inspiration. And I would encourage you to think carefully about ever leaving a baby on less than 1 liter per kilo through a set of high flow prongs, especially if those prongs are mostly filling the nose. So then our which to use and when becomes really straightforward. If you really want to give a baby PEEP, then you should use CPAP. We have many units, if not all units, I think now use high flow widely and use it when weaning from CPAP. And I think we all love doing that. Some have read the Hipster and Hunter trial and decided it's very reasonable to start with high flow, but you should be very prepared to watch those babies closely and escalate them to CPAP early, not leave them suffering and breathing hard in that high flow. And as you saw from the Hipster and Hunter trials, an FiO2 of greater than 0.4 or a pH of less than 7.2, or I think it's 3 apneas per hour, were all triggers to escalate. I wish I could give you an agreement on the starting flow rate in neonates. We really don't seem to have found one, but I will say that the Hipster and Hunter trials are based on 6 to 8 liters per minute, but not on a liters per kilo per minute. But then this other key point, allowing a leak around the prongs is absolutely key. Just drawing circles and measuring the cross-sectional area, a 20% leak looks like this, a 50% leak looks like this. We really want to see our prongs looking like this image on the right, not the image on the left. Again, here's Fisher's and Pickel's image, just to make that mental image of that. Just seeing a tiny rim around here is not enough leak. You need a decent amount of visible leak around there because that's how the babies are breathing out. If you don't have that leak, you're blocking their nose when they're trying to breathe out and you're making their breathing harder for them. So when we think about optimizing our high flow, that leaving a leak is vital to avoid the inadvertently high PEEP, to make sure that we aren't partially blocking the airway on inspiration and not meeting their peak inspiratory flow, and to minimize the resistance to expiration. I would strongly consider not using anything less than 1 liter per kilo. That's certainly become my practice in the last 5 years. And of course, I just think it's always worth just thinking about if it's pressure that we're trying to provide, well, then just measure the pressure. And the chances are at least half of you will have one of these devices sitting around on your NICU that you could easily use to be measuring the pressure on high flow. I'm going to stop there. I appreciate I didn't leave as much time as I'd hoped for discussion. I'm sorry about that, but I do appreciate everybody joining us today. Thank you for your time.
Thank you so much, Dr. Groves. That was awesome. I will open up the floor for questions, but before we get started on questions, I would love if you guys could, at the end of the session, do a QR code or a link for an evaluation. I will leave the link in the chat box, but we'll open it up for questions. Dr. Groves, I think you explained it so well. What are your thoughts about low flow versus high flow when it comes to like those smaller high flow volumes?
Do you mean low flow 100% oxygen?
Yeah, but like when sometimes people will do like 2 liters of low flow versus like 2 or 1 liter of high flow, which I know we don't do that, given that we know that high flow at 1 liters is not effective at all.
Yeah, so again, my suggestion is that we break it down into the physiology and pathophysiology and trying to decide what we're trying to achieve. So if you are trying to give humidification and warmth of the gases. And if you're giving a decent amount of flow, anything more than 1 liter per kilo, I think it should always be warmed and humidified. So I don't think you should do 100% oxygen off the wall at more than half a liter, because then you're giving a lot of flow relative to some of the small babies. And while it's humidified, it's not well humidified because it just goes through that little bubbler and it's not warmed. So that's a bad idea for your ciliary function and your secretion clearance. I do think it's a really good way to give a little bit of oxygen. And certainly the commonest pattern I see with our BPD babies is that we're weaning them down off their CPAP at 32 to 34 weeks. They're staying on high flow from 32 to 36 or 38 weeks. And at some point, we have to make the jump to switch from high flow with a big set of prongs to low flow with a small set of prongs. But it's the prongs that's the key difference between the two. So your other option is to just keep the smaller set of prongs in and make sure there's plenty of leak around them. Or, and apologies to Kelsey, who works for Fisher & Paykel, but Vapotherm have a single prong option, which guarantees you can maintain 50% leak around your prongs because you've only got it in one nostril. Really nice ways to ensure that you've got plenty of leak around there. All I really care about is that we don't entirely occlude the baby's nose while giving less flow than they need while they're breathing in, and also not giving them any way of breathing out. That's just suffocating babies. That seems like a bad idea.
That's all. Yeah, that makes sense. Thank you. Another question in the chat is, in the studies discussed, do you know the type of interface used for CPAP? Was it RAM versus occlusive interface?
So all of those studies use an occlusive interface. I would want to be really clear that RAM does not provide you with CPAP either. RAM also has a long, thin tube going to the baby, and therefore we do not know the pressure drop along the length of that tube, and we also don't know the degree of leak around the prongs. So because the RAM prongs are larger, they will tend to deliver a higher PEEP, but I still don't know what that PEEP is. But they will also then make it harder to breathe out. I know that some centers use RAM with a pop-off and some centers use RAM with a bubble chamber. But again, that is not taking into account the resistance within the RAM circuit itself. And for me, therefore, I feel relatively clear that if we want to give high flow to give washout, we should use a high flow setup and leave plenty of leak. And if we want to give a pressure, we should give CPAP. And I therefore don't see a role for RAM. Apologies to Dr. Ram. He's a far greater clinician than I will ever be. But that doesn't mean that that approach makes sense with the physiology and pathophysiology that we're trying to deal with.
Another question is, from a practical standpoint, how do you view the weaning process to home? On 2 liter, there's no supplemental FiO2 requirements, but to go home, one has to be off high flow and then leading to oxygen presentation on low flow.
Yeah, great question. Practical standpoint, again, it's a very practical answer. It's not fun going home on 2 liters of high flow either. It's pretty unmanageable. If you were there for the first part of the talk, we discussed that a 2 liter high flow actually does give you quite a lot of washout. So 2 liters, 21% oxygen is actually providing the baby with a higher inspired oxygen concentration because of the washout of the dead space. It may also be providing some PEEP depending on the size of the baby and the size of the prongs and the size of the nares. But I will absolutely accept weaning a baby from high flow 2 or 3 or 4 to a low flow oxygen requirement, and then wean that low flow oxygen, because those prongs are tiny, they leave plenty of leak around them, and I can be sure that I'm not impairing the baby's inspiration or expiration. And yes, I'd take most of those babies to a 1/4 liter or a 1/2 liter oxygen, and then I wean them down to an 1/8 and a 1/16, and then stop. And yes, if they can't tolerate that weaning, I'll either keep them in hospital for a little bit longer, or I'll send them home in a trickle of oxygen.